I think that currently oncologists across the globe are witnessing a revolution in the field where the number of genomic treatment options is exploding. And this means that basically every year more extensive genomic profiling is needed to keep up with the guidelines and to make sure that patients don't miss important opportunities. So from a purely medical perspective, it becomes more and more attractive to perform comprehensive genomic profiling techniques such as whole exome sequencing or whole genome sequencing. But of course this is not always feasible in all healthcare systems, so that means that the optimal implementation of NGS testing in the clinic not only depends on medical arguments only, but also on the local availability of resources and treatments.
Indeed, the ESMO Precision Medicine Group has developed this year the update of the ESMO recommendations for perform tumor NGS in patients with metastatic cancer, and it's recommended to perform tumor NGS in patients with non-squamous non-small cell lung cancer, prostate, ovarian, and breast cancer. Also, it's recommended to perform NGS in patients with rare tumors, such as cholangiocarcinoma and cancer of unknown primary. And these recommendations are based in alterations level 1, according to SCAT, which are the alterations that allow to treat patients in the clinical daily practice. It's also recommended to perform tumor NGS in tumor agnostic, of course considering the access to the therapies in the countries where it's possible to treat the patients if we find the genomic alteration. These recommendations, it's important to keep in mind that are for routine clinical daily practice. It's also recommended to perform tumor NGS to detect alterations level 2, according to SCAT, to accelerate clinical research and to enroll patients in clinical trials.
So NGS test results in a vast amount of data of high complexity. So it can be really challenging to interpret the results. So is this really an activating mutation? Is this really a positive mutational signature? But also, what does it mean if something is not detected? Was it not there, or was it not tested? Or was it tested but not detected because of technical issues with the assay or the input material? So these are simply some of the technical challenges that oncologists are facing when interpreting genomics results. And then there are, so to say, the more medical challenges. So what's the clinical meaning of the finding? Which profiles can be successfully be targeted with matching drugs? With the exploding landscape of genomic treatment indications, it can become almost intractable for oncologists to retain a complete picture of all the possibilities, either in standard of care, but also in clinical trials. To address these challenges, we published this year a set of ESMO recommendations on the contents and structuring of a genomics test report in the clinic. And we believe that good reports really take the oncologist by the hand and let them understand not only the technical details of the test, but also the clinical meaning of the results. And then these clear reports can offer a solid foundation for a targeted discussion in the molecular tumor board and with the patient to eventually decide on the best treatment plan.
ESMO provides a large scale of tools to keep the scientists updated and to help the medical oncologists to offer to the patients the treatment with the highest likelihood of benefit. For instance, I can mention the ESMO scale of clinical actionability, that is the SCAT, and also the recommendations developed by the ESMO Precision Medicine Working Group, which were updated this year for the tumor NGS in patients with metastatic cancer.
Yes, and then there's the ESMO magnitude of clinical benefit scale, so that helps you to rank basically genomic treatment indications with similar levels of evidence on the SCAT scale. So if you have two treatment indications that will both, for example, be tested in a phase 3 clinical trial, but one of the drugs is much more powerful than the other, it has a higher magnitude of clinical benefit scale, so it helps you to rank those alterations as well. And then we published this year a set of ESMO recommendations on the contents and structuring of clinical genomics reports that I just mentioned. And ESMO also updated this year the recommendations on the follow-up testing on putative germline variants that are detected with tumor-only sequencing to make sure that patients with hereditary cancers are detected and get the proper follow-up.